Ladies and gentlemen, boys and girls, I'm really excited to have a couple of docs who work at Navajo Nation, which for a lot of us, we know about the Indian Health Service, but it's pretty superficial. So for the ER docs out there, we thought it would be really good to talk to some people that are there in the front lines working in the ERs to give us a sense of both the type of work that occurs there and the population, and in particular in the world's worst healthcare crisis in 100 years, how's dealing with it. So gentlemen, please introduce yourselves. Who are you, where are you from, and where are you now?
Hi, I'm Dr. Paul Charlton. I'm an emergency medicine residency trained physician, and I work here at Gallup Indian Medical Center in Gallup, New Mexico, alongside my colleague, Dr. David Cheever. I'm originally coming from the Washington State area and moved down with my wife 2 years ago to work in the area.
Yeah, and I'm David Cheever. I'm also an emergency medicine residency trained physician who's working out here in Gallup, New Mexico. Originally from the East Coast, and then was out in Washington for residency where I met Paul, and then followed him down here to the Navajo Nation, and now live in Gallup, New Mexico.
Fantastic. So tell us about Gallup, tell us about the Indian Health Service, and give those of us like me that are pretty ignorant a sense of where is this, what is your job, and how does the emergency department fit in with the rest of the healthcare system in the area?
Sure. Yeah, and I think we'd have to start this with an expression of gratitude. It's really a privilege to be part of an excellent team down here at the Gallup Indian Medical Center with the Indian Health Service, and then with our associated tribally administered hospitals that we collaborate with closely. It's a really exciting place to work. It's great clinical emergency medicine, and it's really rewarding. We have had a recent significant experience here in Gallup that I think is a cautionary tale for a lot of other hospitals that are going through something that we've experienced. And I think there are two things that really stand out from that, just as a basic overview. And those are what happens when rural areas experience surges in this COVID-19 pandemic, and what the way that the stressors manifest, and then some of the health equity dynamics in rural areas. But to really understand how that plays out, it does help to understand Gallup, New Mexico. So Gallup, New Mexico is a city. It's in northwest New Mexico, and it's on the southeastern aspect of the Navajo Nation. So the Indian Health Service overall, and we're employees of the Indian Health Service. The Indian Health Service serves 2.5 American Indians and Alaska Natives across 37 different states. And what's that?
2.5 million, I'm assuming, not 2.5.
Million. Yes, thank you. Thank you very much. So the Indian Health Service serves 2.5 million American Indians and Alaska Natives across 37 different states in the United States. And one of those is in the Navajo Nation area. So the Navajo Nation itself has 322,000 individuals in the 2010 census, which is the most recent census data that's available. And that's spread out over the size of an area that's roughly equivalent to the size of West Virginia. Where we work in Gallup is just off the Navajo Nation, so just off the reservation. And we're part of McKinley County, which is a county in northwestern New Mexico that has a little over 70,000 residents, and almost 80% of the residents of McKinley County are Native American. Gallup itself is a city and has about 22,000 residents. That is a number that goes up significantly on a lot of busy weekends or other significant events when significant events are taking place in the region, and the population can swell to 80 or even 100,000. So the Gallup Indian Medical Center is a medium-sized hospital that operates in this area. We're licensed for, I believe, 99 beds, and in practice, we were running around 50 beds, inpatient beds prior to that. The emergency department serves just over 40,000 individuals per year in a relatively rural area. So we're split about halfway between Albuquerque, New Mexico, and Flagstaff, Arizona. About 2 hours to Albuquerque, 2.5 hours to Flagstaff, in what is overall a pretty rural area. Although surprisingly, because of Gallup's dynamics, it feels like more of a county type hospital with quite a few urban issues. It's a really unique place and very rewarding to practice emergency medicine here.
So tell me, 50 beds, maybe you can flex to 99. What services do you have? Do you have neurosurgery? Do you have trauma? If you don't have a service, where do you send your patients if they need inpatient care from a subspecialty?
Do you want to take that, David?
Yeah, so we are a level 3 trauma center, and we are really the only major trauma center in the region. In this side of the state. So the major trauma center for New Mexico is in Albuquerque at UNM, and then obviously Phoenix as well. So we do have trauma surgeons who are on 24/7 at our site. We also have orthopedics, we have OBGYN, we have pediatrics, as well as an internal medicine team. In terms of subspecialties, we sometimes have ENT kind of during office hours, as well as occasionally craniofacial and optometry. But we are limited in terms of bed space, as well as some of those surgical specialties. So we don't have neurosurgery, don't have urology, anything like that. So a fair amount of our trauma patients are referred on to UNM, as well as our complicated medical patients as well. So we don't have a GI service, for example. And so all of our GI bleeds have to be sent out. We don't have inpatient neurology, so all of our strokes also have to be sent out to other tertiary care facilities. And so typically we are sending out somewhere between 10 to 15 patients a day. And that was increased during the cases of COVID and coronavirus, which we'll get into in a little bit.
So another point of ignorance of mine, I'm driving through Gallup and I crash and I need to go to a hospital. Am I allowed to go to your hospital, or is it strictly for Native Americans? Is it open for everybody? How does that work?
That's a great question. Yes, you would be, and in all likelihood, you would be brought to our hospital if you were involved in any kind of trauma. There are 2 hospitals in Gallup. There's a community hospital, and then our Indian Health Service facility. We primarily serve Indian Health Service beneficiaries, although our emergency department will serve anybody that comes through the doors, and that would include all the trauma patients in the region who would be brought by EMS to our doors.
So prior to COVID, let's get a sense of what kind of patient population you're looking after in terms of, is it strokes, is it heart attacks, is it drug related? You know, all emergency departments see slightly different groups of patients. What's the sense of the groups of patients that you're seeing?
So I would say our patient population is actually remarkably complex medically. There's a fair amount of comorbidities within the patient population in McKinley County in this kind of section that we're adjacent to in the Navajo Nation. So a variety of comorbidities related to high prevalence of diabetes, cardiovascular disease that's related to that, as well as strokes. We do have a fair amount of patients who have comorbidities related to alcohol use disorder, and so have a decent amount of liver disease, as well as GI bleeds, gastrointestinal disorders that come into the emergency department on the medical side. We also have a large amount of trauma that cycles through this community here, related somewhat to alcohol use disorder, and also to just how we function as a border town. And so a lot of penetrating trauma, some blunt trauma that comes through I-40, which is the major highway that runs through New Mexico and goes right through the center of our town. And so I've had like a fairly large spectrum of patient population.
You know, I think to add on to that, the one thing that surprised me is I had previously, like most people that train in urban areas, not had a lot of exposure to rural emergency medicine. And my assumption was that it was going to be quieter and that I wouldn't see the same types of things that I would in an urban area. And when I came down here to consider working at Gallup, what surprised me is I felt like I was stepping into a county hospital from decades ago. It was small, it was chaotic, it was strained, it was really exciting. It's very interesting medicine, and it's this unique mix of being in a rural area. So we have to be thinking about hantavirus, we have to think about plague, very rural issues alongside really urban issues, with homelessness and a lot of interpersonal violence and things that are just classically urban emergency medicine. And to be able to practice this in a more full spectrum type of emergency medicine has been extremely rewarding, and not at all what I had assumed rural medicine would be like.
Yeah, that description of your patient population is the same as the county population I work with here in Los Angeles. It's a very similar spectrum of disease, blunt, penetrating, and all the other things we talked about. So you have a high burden of disease, diabetes, liver disease. I don't know, is obesity, I mean, in all of America, obesity is a problem. Is it a problem in the Indian Health Service?
It would be a problem here as well.
Yeah. So you have what is a perfect storm then of a very high risk group for COVID, and then comes along the 100-year, we hope, pandemic. So tell us how that played out. I know initially you thought that it had passed because you weren't getting many patients, and then things changed.
Sure. So we're in a rural area, and we initially felt like, gosh, we must be pretty removed from this new thing that is cropping up in other urban areas and in other countries of the world. But pretty soon we realized we had some fairly concerning vulnerabilities within the communities that we served, and that was motivating. So the Indian Health Service and the Navajo Nation did a fantastic job of mobilizing early and taking this seriously. So we were able to draw on lessons that were being learned from the early outbreak centers through contacts we had in different places, through listening to all the education, the early education that was going out. And because we're in a smaller facility, we were able to implement things very quickly. So in late February, early March, we mobilized a very impressive response and really felt like we were very well prepared. We had PPE, we had a surprisingly stable pipeline for all of that equipment. We did a massive transformation of our space to take advantage of what were seen as the best practices at the time to prepare a facility. And we thought we're as ready as we can be. That was really by mid-March, late March. And we saw other areas that were starting to explode, but they didn't happen in Gallup. So late March, early April, it was quiet, surprisingly quiet. So much that we started to wonder, did we overestimate the risk that we were going to be facing in our community? And then mid-April happened, and we noticed that one of the vulnerabilities in our community that we thought could lead to a significant outbreak did. And within the span of a very small number of days, honestly, it felt like within 4 or 5 days, but definitely within a week, we went from having almost no cases to having a significantly strained healthcare system. So by late April, we were seeing volumes that would have overwhelmed our system if we had not had an outlet to be able to transfer patients to higher levels of care where they could be cared for with the appropriate resources that were needed. That continued to expand at a really concerning rate through the end of April and early May. That required some significant leadership coordination across the state, across the county, across the region, to be able to accommodate the really high demands that we were facing in terms of just these exploding number of cases, the very high acuity of the patients that were coming in, with relatively limited resources for what could be cared for here in our portion of northwestern New Mexico. So much to the point that the state of New Mexico, the governor, had to initiate a fairly significant lockdown of Gallup. And the Navajo Nation did something very similar in order to try to get a handle on this before it fully got out of control. I have to say one of the most heartening things was that through strong leadership with the people at our hospital, at the regional centers, the state, the Navajo Nation, we were able to get ahead of this, though it came really already at a point that we were experiencing a significant burden. And that actually puts us to where we are today. And just to give the actual numbers, the New York Times has been compiling different COVID-19 cases through different sources, state departments of health and the Hopkins case tracker and others. As of this morning, Gallup, New Mexico, and McKinley County are still these are for towns and counties with more than 50,000 people. Gallup, New Mexico, McKinley County is still #1 for cumulative confirmed cases on a per capita basis in the United States. So that's 3,514 cases, which is 48.6 cases per 1,000 people. And we are still #1 in the United States for cumulative confirmed deaths per capita. And that's 2.4 deaths per 1,000 people. So it's definitely sobering statistics. And just as a comparison, on that same tracker, New York City was #2, and that they had 24.5 cumulative confirmed cases per 1,000 people, whereas we were at 48. So sobering statistics for sure.
So why is that? What we're learning about this virus is that it's much more contagious inside than outside. There's a Japanese study, there's a Chinese study that suggests that it's overwhelmingly spread indoors. When I think of Gallup, New Mexico, I think of the Great Plains and outdoors and sunshine. And why do you think it spread so quickly through this community once it got there?
One of the things that we found in terms of the population that was hit first in Gallup, and within that population it spread pretty widely, was some of our most vulnerable members of our community. And what I'm talking about specifically are our homeless shelters, our detox area, as well as some of the skilled nursing facilities that are in our town. And one of the things that's unique, I think, among rural sites, so not unique to our site in particular, but among rural sites, is that when you start to see the social structures of your community being stressed, that gets reflected really quickly in the emergency departments and in the hospitals. And so what we found was that one of our high utilizers, this is kind of as Paul was mentioning, so we had our first case on March 16th, and then started to see, so towards the end of March, early April, had one of our high utilizers that tested positive. We did some contact tracing for him and for that particular patient, and found that that patient had been in our detox area. And then did contact tracing for patients who'd been in that same detox facility as well as other homeless facilities. And that was really where our cases had spread. And there was a lot of kind of communal areas within those facilities, and quickly had to adjust on a community level to, well, now what are we going to do with our homeless patients? Now what do we do with our patients who need the services that are related to detox? And had a pretty great community effort to create the hotel motel program, which is now set up here, where we have about 120 to 150 patients at any given time in the hotels and motels in Gallup, which has been a real success for the community, and has been spearheaded by some of our internal medicine group. But to specifically answer your question, I think it's vulnerable populations in some of those communal settings, and indoors. And Paul, do you want to speak a little bit to how that might be reflected on the Navajo Nation itself, and not just within Gallup?
Sure. Yeah. So the CDC's Office of Minority Health and Health Equity talks about 3 broad factors that are associated with many of the disparate health impacts in infectious pandemics, and they're not specific to what we've experienced in the Gallup area and this portion of the Navajo Nation. They really apply to a lot of communities, probably almost every community in the U.S. But those 3 factors definitely do seem to help explain part of what we've seen here. So one is that certain communities, minority communities, are more likely to contract the infection. They're more likely to have more severe disease course if they do contract it, and then they're more likely to have difficulties accessing care or face discrimination with that care. So in terms of our particular context, ways that this may have been contributing to this really high prevalence that we've seen, more likely to contract the infection. There are some physical distancing limitations in this region that are notable. If we were to fly over the Navajo Nation, I think we would initially feel like there aren't very many people here. But then when you actually look more closely, there are a lot of homes in the area, and many of those homes are clumped fairly closely together, though they may be spread out. These units may be relatively spread out from one another otherwise. Within many of those homes, there often is a degree of overcrowding that makes it hard for somebody to physically isolate themselves if they do contract a SARS-CoV-2 infection. And thus it's more likely that they're going to spread it to other members of the family. And there are some really positive things in the region about multi-generational households, which has been a protective factor and something that overall has been really quite helpful, especially when you think about people being able to stay at work and all the kids who are out from school. But it also may mean that you do have multiple generations that are at risk of getting sick from one person coming back from an exposure. Secondly, there are a lot of economic pressures in the area for people to stay at work, including in some high risk positions, and many people just don't have the privilege to say, I'm going to stay home from work and not get paid. So there are those other pressures that do make it more likely that people are going to contract things. And then there has been a third component of that, which is it is a little bit harder in some households to do the types of preventive mechanisms that would prevent spreading. So some households don't have access to running water inside and may not have access to electricity. And that makes this very hard in a way that in some other urban areas, we often don't think about that. In terms of the second topic of what makes people more likely to have a more severe disease course, we do see higher rates of diabetes in American Indian, Alaska Native communities than in other communities. And there are other comorbidities that do place people at slightly higher risk for having complications. And there may be other factors that have yet to come out because we're still relatively early in this. And then for the third part, difficulties accessing care and then discrimination in that care. That is something that I think we all do need to be looking at, ways that we might be feeding into that. So there are challenges with transfers. There are financial implications when people get transferred far away from their homes in terms of family coming to visit, repatriation, going back home from wherever that hospital was that they were sent to, language challenges, which are a big challenge within our hospital, let alone in many of the other regional hospitals that may not have native Navajo speakers in person to be able to help with interpretation. And then experiences with discrimination, bias that we know can be explicit and implicit. And then finally, challenges that many of our patients have faced when they went to other urban hospitals that were not familiar with some of the social and logistical limitations at home. So people get sent home assuming that they have electricity and they have running water and they have all the other things that they need to be able to isolate, and they don't. So I think those three factors we do see play out in our region, that we'll need a little bit more time to know exactly how each of them contributed.
Yeah, that's not the normal discourse on discharges. Do you have electricity? Do you have running water in most of the US? So that's a particular skill that you'll have to develop if you work in these areas. So can you give us again a color commentary now of when it got to its worst? How many patients were you seeing? And I'm assuming the hospital quickly got overwhelmed, so you're having to transfer people. How does that work when the nearest big hospitals are hours away? And how many times a day were you doing that?
Yeah, so typically during kind of our busier season, just to give you some context on the numbers, we were seeing about 150 patients a day. This is pre-COVID. As the coronavirus hit harder, and we were seeing increasing populations, or percentages of our patients who had COVID-19, beginning again kind of early April, mid-April through May and early June. We were seeing numbers, so other people were not coming to the emergency department, which I think we're seeing typically kind of across the country. And so we were seeing patient populations of about 80 or 100 patients a day. Which still put a pretty significant tax on our system, given the PPE requirements, changes we had to make to the physical structures that limited some of our rooms, and the limits we had just with negative pressure spaces for aerosolizing procedures. When we were at our highest in terms of COVID-19 cases, we were seeing about 80 to 90% of our patients who were COVID positive. And those patients were all coming in with COVID symptoms. So it wasn't that they were COVID positive and they came in for something else. And so we had to create systems that were pretty quick to be able to disposition them. We have 6 ICU beds in our hospital, and those were quickly overwhelmed. So we came to a decision with our hospitalist group that essentially we would keep 2 of those ICU beds kind of always open for patients that were quickly deteriorating, and we would transfer most of our critically ill patients to mostly Albuquerque. Luckily, at that point, Albuquerque was not seeing an increase in their COVID patients, and they were seeing the decrease in patients overall that was being seen in the rest of the country. So they were very happy to accept our patients. And it created a command center that we could call that would help disposition patients to whatever hospital, whether it was UNM or some of the private hospitals in the city that had openings, either on the ICU or just the floor level. And so pretty much anyone who was coming in who had higher than 4 liters on nasal cannula oxygen requirement was getting transported out. And that put a significant strain on us because it was several hours to be able to transport those patients to Albuquerque. And most of those transports were by flight and were not by ground transport. And so what we created with our hospitalists is that we actually had some negative pressure rooms that were on the floor and in the ICU that were essentially like OBS area, where we would figure out a disposition. That patient was going to be flown to UNM, for example. They would go into the ICU, spend a few hours there, but they would at least be out of the emergency department and they could be transferred over. And then we ran into significant limits. So at the height of it, we were intubating somewhere around 3 to 5 patients a day within our emergency department. And that was not just in our emergency department, it was also on our floor. And given the availability of our CRNAs who are fantastic, kind of our anesthesia colleagues here, but given some of the limitations with scheduling overnight, we're responsible for most of the airways. So we're taking care of airways on the floor as well as in the ICU. And quickly would run out of negative pressure spaces and had to be creative about creating spaces for resuscitation and aerosolizing procedures outside in a critical care tent that we had set up or just in the ambulance bay.
That is pretty remarkable. Wow. So would you send a patient at a time on the plane, or would you, because I can assume like you have to clean the plane, put the patient on, they fly, they drop the patient off, they have to fly back, they have to be cleaning. I don't know how many times a day you could do that. Did you put 2 or 3 patients in a time? How does that work?
We did not. We were able to maintain the same standards of care that we would have wanted pre-COVID. So during the peak periods, we were Gallup, between Gallup Union Medical Center and our collaborating community hospital in town, we're sending about 1 patient per hour to the Albuquerque area hospitals, which, as you can imagine, is a significant strain on the flight services. We do not have regular ground transportation, so everybody flies. That's pre-COVID and post-COVID, and that's a lot of patients to be flying. So David touched on this what we call the transfer observation pathway, where we deliberately tried to keep 2 negative pressure rooms in the hospital open at any time. And that was because it was not uncommon for us to have an emergent case come in where we've intubated a patient in our 1 negative pressure room in the ED. And then we have another emergent patient who comes in and we intubate them outside in the critical care tent. And then both of our main areas are now full, which means we have to very rapidly move somebody away. And if the flight services are backed up because they're already en route somewhere else, this becomes much more crucial for us. So our hospitalists, thank goodness, were very much on board to helping. So we kept these 2 rooms open. We would immediately, essentially after being intubated and stabilized, we would wheel them up to the ICU, where the hospitalists would observe them until a flight service could come in. And maybe that's 2 hours, maybe it's 5 hours, so that we could at least get one other room turned over so that for the next patient coming in, we had a place to do intubations. That was pretty stressful and that went on for quite a while. Thankfully though, I feel like we never had to compromise from the expected standard of care. And again, I do want to give credit to all our colleagues here at GIMC, Navajo Nation, and the State Department of Health for really working hard on a very coordinated system. That's the only way we survive this.
It's an overwhelming number of transfers. I mean, that's like a MASH unit on the front line of a war, having to fly somebody out every hour. That's incredible. So you've passed the peak for now, like the rest of us. Or actually here in California, we are climbing the peak right now. But what lessons, what are the sort of the biggest takeaway lessons you'd have? I think particularly for rural docs, not just here in the US, but throughout the world that are going to watch this, what would you say to them about preparation, about logistics?
So I think this issue of thinking through what is our coordinated leadership strategy going to be ahead of time while we still have a breather was one of the biggest things that allowed us to manage through this without ever getting to the point that we worried about rationing care or doing anything that wasn't at the appropriate standard of care. So that meant not only coordinating within our emergency department so that we had our plans together within the hospital, but also between our neighboring hospitals, with all of the EMS services, and then with the leadership in the region. So the state of New Mexico, the state of Arizona, and the other hospitals within that region. So both Arizona and New Mexico had set up transfer lines, and we had weekly calls with them. It ultimately was probably 3 times a week that we were speaking with them. And that was really crucial for both figuring out a system, then launching the system when it needed to get launched, and then giving feedback. So for instance, these issues where we're having people getting discharged home without appropriate discharge planning, and then they drive back into Gallup and drive straight to our hospital again, we were able to give feedback to help with that. So the coordinated leadership, I think, has been one of the most important things. I think a second thing has been identifying vulnerable communities and realizing that being attentive to them and caring for them is a really crucial part of caring for the entire community. And every community has marginalized elements to it. And initially it can be hard to get some traction with that, but I feel like recognizing the importance of being aware of the landscape, aware of the vulnerabilities, and then putting in place systems to address that was really important, while also being aware that some of the narratives can feed into bias. That's been one of the less heartening things that I think we have witnessed across the US, but then also in this area. And there has been increased amounts of discrimination and bias that is coming in based on the way that we're sometimes not careful about how we communicate vulnerabilities and causes for what's going on. So those would be some lessons that I'd want to highlight. David, what would you have?
Yeah, and I think to further support that in terms of the our most vulnerable populations is reaching out to the community members that are already doing things for those populations, and the people who are leading the organizations that are best serving them, and bringing them on in these discussions with the local government leaders as well as state leaders, and leaders within your hospital, and making sure that they're on board with whatever you're going to be doing. And that's especially important in a rural situation where there's not that many people doing these things. And if you don't have buy-in from people who are running your local homeless shelters or your local detox center, you're going to have major limitations in what you can do for the population. And then I will say the other thing that I think is really important as you're looking forward is making sure that you're just continually moving and improving on the processes that you put in place. I think it's easy to put something in place for whatever current crisis you're dealing with and kind of pat yourself on the back and say, we've handled this, and not keep moving forward, because I feel that we did have this surge that kind of happened in April, but we're going to have another surge pretty quickly, and we're seeing cases increasing in Arizona as well as in Texas, and a lot of the structures that we put in place in April are not going to work for us going forward as weather gets colder, as some of the temporary structures are just degrading in the setting of some of our weather, just as an example, and just continually pushing to move forward and to anticipate what's coming next, because we recognize that this is going to be with us for a while.
I think the other thing that was alarming from our experience was just how quickly things changed. So we went from a very comfortable space to within a week, just a totally different scenario. And that is alarming to think that could happen to us again, or that it could happen to similar communities like Gallup across the country.
It's your experience has been shared with a number of people, this idea that you can go from 0 to full on within a few days. And now that's been noted all over the world. Chile is an example. Our colleagues there were like, we think we missed this. And then 2 days later, they're like, oh my gosh, I've never seen so many patients with viral pneumonia. We are not taking down our tents at LA County for those reasons. We're seeing the surge come, and we're looking forward in the next few months thinking this could be worse than it was the first time. So I think we're all in this together trying to work out how to do it. So all of these stories become very useful. So before we finish here, a little bit about practicing in the Indian Health Service. I'm sure you need recruits. Has this been, I mean, you seem like you really love this work. Do you love it as much as it seems like? And should other people come and do this? I mean, it seems like a very unique experience.
Why don't you start, David?
Yeah, I absolutely. This has been exactly what I was looking for out of residency, and I think long term as well. It's work with purpose, and it's the kind of medicine that I've been attracted to and wanted to practice. So Ken Bernard, who's an emergency medicine physician who was medical director at Tuba City, which is on the other side of the reservation, did a study that was published in the Annals of Emergency Medicine in 2017, where he looked at IHS hospitals and looked specifically at emergency department physicians and what percentage of them were emergency medicine trained and board certified. And less than 15% of the emergency medicine physicians that are working in ERs across the Indian Health Service are board certified residency trained emergency medicine physicians. And so there is a huge need throughout IHS hospitals, as well as across rural communities throughout this country for the work that we do and the expertise that we have. And it's really, it's just a great experience working out here and feeling like you're contributing.
Yeah, I would echo that. It's a fantastic place to work. I think many of us starting in medical school had to write little essays about what we hope to do with all this training. And I remember what I wrote, and essentially that's what I'm having this very lucky opportunity to put into practice right now. Rural medicine, I mean, it's got its own challenges and opportunities. Resources can be sparse. There are significant clinical challenges without a lot of backup, and so people have to be pretty confident with that. But boy, it's a tremendous opportunity to get to practice full spectrum emergency medicine that we train for in a context that is on a very human scale. Where individuals can make a difference and where there's often a strong sense of community that really is fulfilling. So I really, from my personal experience, can only say positive things about how rewarding this has been and how unique the opportunity is.
Well, thanks for taking the time speaking to us. I know that rural docs across the world are really going to appreciate the time you spent. So thank you.